Thank you very much for your kind introduction. Good afternoon, everyone. Today, I will present the incidence of tuberculosis and associated risk factors in children living with HIV based on the data from the Treat Asia Pediatric HIV Observational Database, or TApHOD. Before I begin, I would like to declare that there are no conflicts of interest to report to this presentation. Children living with HIV are at particularly high risk of developing tuberculosis in the first 3 months of antiretroviral therapy. TB remains the leading cause of mortality in this population. Our primary objective was to describe the incidence of TB after starting ART and to determine the TB-free probability after 5 years of ART. Secondary objective including predict factors associated with the development of TB in children living with HIV. This was the multi-center observational study including 18 sites in 6 countries. We included children and adolescents who initiated first-line ART on or after January 1, 2013, when aged less than 18 years old. We excluded those who diagnosed with TB within 6 months prior or 1 month after ART initiation to exclude the prevalent TB. The main outcome of this study was the incidence of clinically or laboratory confirmed TB after ART initiations. We analyzed the characteristic at ART initiation, calculated the incidence rate of TB per 100 person years, and used Cox proportional hazard models to identify the predictor of first TB. Key time updated variable included age, weight for AC score, the immunodeficiency status, HIV viral load, and second-line ART. About the definition, the ART means at least 3 drugs of antiretroviral medicine. The baseline means the date of ART initiation. TB definition type included lymph nodes, pulmonary, extrapulmonary, or disseminated types. The WASP definition based on 2006 WHO standards for children less than 10 years old or CDC standards for those more than 10 years old. Severe immunodeficiency defined using the WHO criteria 2007 based on age and CD4 criteria. From over 8,000 patients in the Pediatric IEDA Asia Pacific cohort, 2,486 met our eligibility criteria after excluded those who had TB at ART and who had TB within 30 days after ART. 2,160 children and adolescents were included in the final analysis of TB incidence. Among them, 87 developed TB during follow-up, included lymph node, pulmonary, extrapulmonary, and disseminated cases. This slide shows the baseline characteristic of the children and adolescents included in the final analysis. 53% were male and nearly half was under 5. The median age at ART initiation was 6 years. The median CD4% for children under 5 years of age was 18%, and the median CD4 cell count for those more than 5 years was 278 cells per cubic millimeters. 77% were severely underweight. TB incidence peaked in the first 90 days after ART initiation with a rate of 4.04 per 100 person year and decreased substantially after that. The overall TB incidence was 0.86 per 100 person years. This slide shows the TB incidence stratified by age group at ART initiation. You can see that the highest risk group was the children under the age of 1 year. This slide shows the TB incidence stratified by the immunodeficiency status at ART initiation. Children who had immunodeficiency had a higher TB incidence compared with those without immunodeficiency. This slide shows the factors associated with first TB after ARDS using the multivariate and univariate analysis. The first predictor was the age under 1 year with a markedly elevated risk of develop first TB with an adjusted hazard ratio of 3.83. The other factors is the severe immunodeficiency status. These were found to have an increased risk of first TB after ARDS with an adjusted hazard ratio of 4.25. Additionally, children with a viral load of 10,000 copies per millimeter or higher had a higher risk of first TB after ARDS with an adjusted hazard ratio of 3.9. Additionally, the severe underweight status defined by the VAS below -3 with an adjusted hazard ratio of 2.6. Moreover, receiving care at the university-based hospital also associated with a higher risk of TB after ARDS with an adjusted hazard ratio of 2.42. This study had several limitations. Being an observational study in nature, it relies on routine clinical data that may be incomplete or inaccurate information, especially regarding misclassification of TB types. Also, some variables such as CD4, viral load, and nutritional status has missing data which might have influenced the risk factor estimation. In conclusion, in the first few weeks after starting ARDS are critical for TB risk. The highest risk group are the children with very young age, those with current low CD4 or current high viral load, and those who are severely underweight. I acknowledge support from the Treat Asia program of MFAR and from the multiple US NIH institutes and as well as the Kirby Institute of Australia. I am grateful to all contributing sites for this pediatric research effort. Thank you very much.
Yeah.